Hello and welcome to the ISN KDIGO webinar, Acute Kidney Injury in 2019. And we'll be talking about what has changed in the guidelines since 2012. I'm John Kellum from the University of Pittsburgh, and my co-presenter is Marlies Ostermann from London. We'll be taking questions in throughout the presentation. We'll be addressing them at the end, but you can type your questions into the question box as we go, so don't hesitate to do that. And then at the end of the presentation, we'll have time for answers to those questions. So we'll begin with Marlies Ostermann will start us off. So please go ahead, Marlies.
Thank you, John. It's a great honor to present this webinar together with John Kellum. The KDIGO guideline was published in 2012. This document was a great success, and it's still considered a landmark document relevant to clinical practice. It contains more than 140 recommendations based on more than 18,000 publications until 2011. It covers a wide range of topics, from acute kidney injury diagnosis to risk management and prevention. It also includes guidelines related to the management of acute kidney injury, including renal replacement therapy. At the time, the KDIGO expert committee did a fantastic job in merging various different definitions of acute kidney injury. And they developed the KDIGO criteria for the diagnosis and staging of acute kidney injury. Accordingly, as shown here, acute kidney injury is defined by either a rise in creatinine from baseline, or a fall in urine output, or the initiation of renal replacement therapy. These criteria are still valid, used in clinical practice, and often used in clinical research studies. At the time, the expert committee was clearly aware of the rise in biomarker studies and the development of new biomarkers to define acute kidney injury. And at the time, they proposed a research recommendation that new biomarkers needed to be explored and investigated in future research studies. Since then, we've seen many more biomarker studies and many more new biomarkers. These biomarkers have been detected, studied, validated, and reported in the literature. And just as an example here, we have developed and become aware of biomarkers from different parts of the nephron, giving us different information about the nephron and the kidney as a whole. When used appropriately, these biomarkers can not only advance our understanding and knowledge of acute kidney injury, but they can also help us in clinical practice, because some of these biomarkers help us diagnosing acute kidney injury earlier. Others help us prognosticating and guiding future management. As an example, here is an important paper by Professor Hase and colleagues, which illustrated the concept of preclinical or subclinical acute kidney injury. This is a concept highlighting the fact that acute kidney injury or acute kidney dysfunction may occur before we see a rise in creatinine. And that's actually quite important, as shown here. Patients who were biomarker positive without a rise in serum creatinine had a significantly higher risk of needing renal replacement therapy or dying compared to patients without a biomarker rise. So clearly showing that acute kidney dysfunction or acute kidney damage may occur before it is noticeable to us and indicated by a creatinine rise. Now, the key question is obviously how to integrate these biomarkers in a future guideline and in a future definition. And I think that's something which is for the community, for the critical care nephrologists and all relevant specialties to decide in future. The previous guideline also introduced the concept of acute kidney diseases and disorders, called AKD as an abbreviation. AKD describes the period of kidney disease up to day 90 when CKD begins. And clearly, this is an important phase because we know this is a period where kidney function may recover or deteriorate. It's the period where we now know a large number of patients progressively develop chronic kidney disease. And we've now learned that acute kidney disease is associated with short and long-term outcomes and significant disabilities, as shown here. Professor James and colleagues from Canada performed a retrospective analysis of a large healthcare database and demonstrated the importance of AKD. And as shown here, in fact, AKD was much more common than acute kidney injury. And more importantly, almost 50% of patients met criteria for AKD without meeting any of the criteria for acute kidney injury. The previous AKI guideline touched on AKD, but at the time did not highlight any recommendations or management strategies. And clearly, more guidance is necessary to inform clinicians how to best manage these patients and prevent poor outcomes. So in summary, in the field of AKI and AKD, there are still several areas where new knowledge has emerged and clarification is urgently required. We have no agreed definition for persistent versus transient acute kidney injury. We have little information and guidance on how to manage AKD. And as illustrated, we've not made use of these new biomarkers, which can give us a wealth of new information and potentially change clinical management. Risk assessment was an important part of the AKI guideline. And as it stands at the moment, the KDIGO guideline recommends that patients are stratified for risk of acute kidney injury according to their susceptibilities and exposures, and that they are managed accordingly. Clearly, this makes sense. The only problem is that we have many different risk scores for different patient populations and different outcomes. And at present, we do not have a universally accepted risk prediction score for all patients, applicable to all patients universally. But new tools have emerged since the publication of the KDIGO guideline. So we have new tools and new techniques to assess patients' risk for acute kidney injury. As an example, I've listed the Renal Angina Index or the Renal Functional Reserve Assessment, and again, biomarkers, because they've helped us risk assessing patients. The concept of renal functional reserve is particularly exciting. It provides an assessment of an individual patient's risk for developing acute kidney injury. In this paper by Professor Ronco and colleagues, patients were scheduled to have cardiac surgery, and in order to assess their risk for acute kidney injury, they underwent measurement of renal functional reserve before surgery, a few days before. And as shown here, patients with reduced renal functional reserve had a significantly higher risk of developing acute kidney injury compared to patients with adequate renal functional reserve. So this tool allows a more individualized assessment of patients' risk for acute kidney injury. Biomarkers can also help risk assessing. They've been used often in combination with creatinine to assess a patient's risk for acute kidney injury. In this paper, for instance, the authors measured cell cycle arrest markers in patients admitted to the intensive care unit. And as shown here, patients with acute kidney injury and a positive biomarker had a significantly higher risk of needing renal replacement therapy or dying compared to patients who had acute kidney injury without a positive biomarker. The question is obviously whether the integration of these biomarkers in the risk assessment makes a difference to patients' outcomes. And the exciting news is that several reports have reported success in integrating biomarkers and influencing clinical decision-making, resulting in better patient outcomes. As an example, we have here one study where biomarkers were integrated into a risk score. We've got studies here, intervention studies, where biomarkers were used to identify patients at highest risk of acute kidney injury so that clinical decision-making could be modified and interventions could be adjusted. Again, a study using biomarkers to risk stratify patients for particular interventions. And finally, one more study looking at biomarkers at admission to the intensive care unit and the subsequent change in clinical management. So the use of biomarkers is particularly exciting when risk assessing patients and modifying and influencing clinical decision making, resulting in better patient outcomes. Biomarkers were not included in the previous chapter of the AKI guideline, but again, should be considered in a future revision. We've now even had biomarkers which indicate risk of acute kidney injury before an exposure. Here's an exciting study which has just been published, which identified patients at high risk of acute kidney injury after cardiac surgery and at high risk of subsequent kidney function loss before undergoing cardiac surgery. The biomarker of note was a urinary cytokine, urinary DKK3. So clearly this field is emerging and will, I'm sure, impact a future revision of the guideline. A large part of the guideline deals with the management of acute kidney injury. The guideline recommends a stage-based approach, as shown here. Importantly, these guidelines and these management recommendations are still valid for clinical practice. All the recommendations listed here are still relevant to bed management at the bedside in modern clinical practice. Fluid and hemodynamic management are strongly recommended. The guideline, as it stands at the moment, recommends that crystalloids rather than colloids should be used for the prevention and management of acute kidney injury. However, the expert committee already recognized that fluid studies were being conducted and that different types of fluid may have different impact on the risk of acute kidney injury. At the time of the guideline, the expert committee recommended that more studies were necessary to identify the optimal type and optimal volume of fluid for prevention and management of acute kidney injury. The good news is that some of these studies have already been conducted and completed, and some studies are still ongoing. For instance, the SPLIT trial was a feasibility randomized controlled trial in 2 centers in Australia, comparing chloride-rich versus chloride-poor solutions. It showed no difference in the incidence of acute kidney injury. In contrast, more recent, larger randomized controlled trials have shown that patients who received more balanced solutions had better renal outcomes and better outcomes in general compared to patients who had received saline. Several other studies are still ongoing and will be reported in the next future. So clearly, in a future revision of the KDIGO guideline, these fluid studies will need to be considered, and the guidance on fluid will have to be more crystallized. Another component of fluid therapy is volume. And it's become clear over the last few years that fluid overload is a serious risk factor for poor outcomes, including poor renal outcomes. Both hypovolemia and hypervolemia are considered to be harmful to kidney function. This was highlighted in some of the recent studies, also showing and emphasizing that volume of fluid may actually depend on the setting and the individual patient population. Here we have the RELIEF trial, which compared restrictive versus liberal fluid therapy in patients undergoing major abdominal surgery. And in this patient population, there was a higher incidence of acute kidney injury in patients randomized to the restrictive fluid arm. In contrast, the classic feasibility study in patients with septic shock showed that fluid restriction after initial resuscitation was not harmful. And in a retrospective analysis of critically ill patients, it was shown that fluid administration, excessive fluid administration in particular, in patients with acute kidney injury was associated with a higher risk of progression to severe acute kidney injury. So volume of fluid matters, but the impact depends on the clinical setting and the patient population. So in conclusion, these recent fluid studies have given us more insight into the complexity of fluid therapy. Despite these large number of studies, many unanswered questions remain, and a future guideline will have to be more specific with regards to the type of fluid, the volume of fluid, the strategy of monitoring fluid therapy, and finally, how to deal with fluid overload and fluid removal. Now, at this stage, I would like to hand over to Professor Kellum. And as we've already said, Professor Kellum was the co-chair of the previous KDIGO AKI guideline. And as a professor of critical care medicine and director of the Critical Care Nephrology Center in Pittsburgh, he's an international expert with a wealth of knowledge in this area. So I look forward to his presentation.
Thank you, Marlies, and thank you for covering the first half of this presentation and covering what's new in a variety of areas around acute kidney injury. And carrying on from the last section that you spoke about in terms of fluid management, hemodynamic management, including vasopressors, are obviously a closely related topic. And the previous guideline recommended that when vasopressors are used, and to use vasopressors in conjunction with fluids in patients with vasomotor shock, with or at risk for acute kidney injury. There were some areas where research was still controversial, and there were questions about what might be still needed. In particular, the target for mean arterial pressure in patients who have perhaps history of severe hypertension, particularly if that hypertension is not well controlled. And I think the message here really is that there's not a single blood pressure target that applies to all patients with vasomotor paralysis, and one needs to individualize the therapy and perhaps give higher mean arterial pressure targets to patients with chronic hypertension. The other unanswered questions, I think, relate to the type of inotrope or vasopressor that might be used to manage cardiac dysfunction or vasomotor paralysis, respectively. And there are some newer agents that have become available in targeting different mechanisms, and recognizing that in patients with and at risk for acute kidney injury, renal hemodynamics play an important role, both in terms of the macrocirculation in and out of the kidney, as well as the renal microcirculation. And obviously the pressure in the glomerulus is a large determinant of GFR, and manipulating afferent and efferent arteriolar tone has been looked at as a potential for both therapy for acute kidney injury, as well as recognizing that unintended manipulation of those tone of those vessels will perhaps further jeopardize renal hemodynamics and perhaps even renal perfusion. There have been a number of studies which have looked at protocolized-based care in terms of renal hemodynamic optimization in the setting of septic shock. This study was one of 3 studies which looked at the role of early goal-directed therapy compared to usual care, which was at the discretion of the clinical team, and a third protocol, which was protocolized standard therapy, which did not include blood transfusions and inotropes and some of the other features of early goal-directed therapy, and was not guided by mixed venous or central venous saturations. The results of this study were negative in terms of total all-cause 60-day in-hospital mortality, which was the primary endpoint. Death by 90 days was not different either. Interestingly, the presence of new organ failure within the first week nearly made statistical significance for cardiovascular, and was statistically different, favoring usual care, or at least not favoring the protocol-based standard therapy, which was the arm that received the most fluid when we talk about the rate of renal dysfunction defined by new dialysis. There have been, as I said at the beginning, there have been a number of studies looking at high versus low blood pressure targets in patients with septic shock. This multi-center open label RCT randomized 776 patients undergoing resuscitation and compared the target mean arterial pressure of 80 to 85 versus a more traditional 65 to 70. Overall, there was no difference in 28-day or 90-day mortality, but a subgroup analysis of patients with chronic hypertension indicated a marginal, at least statistical benefit for higher mean arterial pressures in patients with chronic hypertension. It is not known either which vasopressor is most effective for prevention and treatment of patients with AKI and septic shock. Most studies have focused on norepinephrine, dopamine, or vasopressin. And there have been a number of analyses of a number of trials and a number of subsequent analyses looking at these individual biomarker or these individual vasopressors. However, the new information is contained in this trial. This was a sub-study of the ATHOS-3 trial. And the ATHOS-3 trial looked at the use of angiotensin II as a novel strategy for treatment of refractory vasodilatory shock. And overall, the study showed that the use of this agent was successful in raising blood pressure, which of course is not particularly surprising given the way in which the drug works. But more importantly, perhaps, is there was a hint that in this sub-analysis that there may have been further benefit in patients with severe acute kidney injury, at least requiring renal replacement therapy. And so overall, the question remains as to whether there should be a selection of vasopressors based on background risk, including acute kidney injury, and that not all patients with septic shock or shock refractory to fluids and low-dose vasopressors should be treated equally. This is the survival curves, or actually this is the cumulative incidence of discontinuation of renal replacement therapy in a Kaplan-Meier format for both placebo and angiotensin II. This information suggests that there is potential for better probability of liberation of from renal replacement therapy, which would include both survival and ability to come off renal replacement therapy when angiotensin II is added to the therapy. Again, I have to point out that this is a post hoc analysis of a subgroup that was analyzed from the larger trial, and at this point, I think we would have to agree is hypothesis generating more than solid evidence of benefit within this subgroup. Nevertheless, it's interesting and certainly something that will be the focus of further investigation. In addition, various drugs have been associated with increased risk of acute kidney injury. The previous guideline had a variety of recommendations around minimizing risk associated with various types of nephrotoxic agents. Interestingly, as Marlies has already pointed out, the recommendation for isotonic sodium chloride has now been, I think, challenged by more recent studies that would suggest that balanced chloride or balanced crystalloids have an important role in that setting. There was also at the time a fairly robust evidence that oral N-acetylcysteine would be effective, although even at the time it was a 2D recommendation. Subsequent studies have called into question that approach. In particular, the question as to whether or not contrast is a significant risk for the kidney when it is given, particularly in small doses, as is current practice, and using more modern radiocontrast agents, which, unlike historical agents, have a much lower risk of acute kidney injury. The conclusion of this study suggested that, or showed that, or stated that intravenous contrast administration was not associated with an increased risk of AKI or emergent dialysis and short-term mortality in ICU patients with a pre-contrast EGFR greater than 45. An increased risk of dialysis was observed, however, with patients with lower EGFR. I think this puts into context what our current sense is, that for the average patient without chronic kidney disease or any other significant risk factors, contrast is actually a very low risk. However, there are subgroups of patients, in particular those with chronic kidney disease, who continue to have a demonstrable risk associated with radiocontrast. In terms of actually addressing that risk with either sodium bicarbonate or N-acetylcysteine, this study will likely be the final word on this question. This was a very large randomized controlled trial published, obviously you can see, well after the 2012 guideline. This study showed that there was no benefit from intravenous sodium bicarbonate or oral N-acetylcysteine for the prevention of death, need for dialysis, or persistent decline in kidney function at 90 days, or prevention of contrast-associated AKI in the short term. There are still ongoing analyses of various high-risk subgroups within this study, but I think it's fair to say that overall, for the average patient, there's really no longer a role for the use of these particular agents to mitigate the risk of contrast-associated AKI. I think overall there's a question, however, that's emerged not just with contrast, but with other agents as to what constitutes a nephrotoxin. And certain drugs may be associated with the development of AKI or manifestations of AKI without necessarily being nephrotoxic themselves. Partly this occurs because the indication for certain drugs, in particular certain antibiotics, may occur or obviously occurs in patients who have an indication such as sepsis, which itself is associated with acute kidney injury. The same thing is true for certain cardiac drugs given for patients with MI or heart failure, or who themselves have a risk because of their underlying disease process for acute kidney injury. This is part of the argument about radiocontrast, that obviously you don't give radiocontrast for patients without a disease process that you're investigating, and sometimes the disease process may be the cause of the AKI rather than the drug. Nevertheless, there is a substantial risk for nephrotoxicity with many of the drugs that we use, and sorting out the added effect of the agent versus the reason you gave the agent is an active part of research in many parts of the globe. One framework for looking at this particular relationship is to consider the fact that sometimes renal function will be affected by a drug, and sometimes there will be evidence of kidney damage, usually manifest by biomarkers, and sometimes there will be both. This framework has been used to help us understand manifestations of acute kidney injury in various areas, but in particular, for drug-associated AKI, it is useful to use this framework to understand whether or not the drug is impacting either function or actual injury to the kidney, or both. This change in renal function that occurs, for example, with ACE inhibitors has garnered particular interest among the cardiology community, and I think that many have questioned whether or not small changes in renal function are simply a price one pays for using an agent which has significant benefit in the management of heart failure, for example, and to label that as a nephrotoxic effect is problematic. On the other hand, if there is a substantial diminution in renal function as a result of the drug, that cannot be ignored either. So this controversy will likely continue to play out in upcoming guidelines. So the remaining questions in this area include how should drugs be classified in terms of their nephrotoxicity potential? How should exposure to a potentially nephrotoxic drug be monitored? When should potentially nephrotoxic drugs be restarted after acute kidney injury, when the patient may have a frail kidney that is more susceptible to nephrotoxins and other renal insults? Is there a role for nephrotoxic drug stewardship overall as a way of reducing nephrotoxicity in a variety of different settings? The final chapter in the prior guideline was the topic of renal replacement therapy, and there were a variety of mostly ungraded recommendations around initiating renal replacement therapy in emergent situations, and considering the broader context of conditions which can be modified by renal replacement therapy. Clinical practice includes those various features of the clinical course, not purely based on single measurements of biomarkers such as BUN and creatinine. Similarly, discontinuation of renal replacement therapy is recommended when it's no longer needed. That's sort of self-evident, but assessing that and how one assesses that continues to be a subject of significant variation in clinical practice. Several research recommendations for determining reproducible criteria such as fluid overload, biomarker level, severity scores to inform the decision to start renal replacement therapy in adult and pediatric AKI patients, and to determine whether early or late initiation of renal replacement therapy based on such criteria results in improved clinical outcomes. And there have been studies. This is one of them. This is a very robust study that looked at the question of whether a strategy of an early initiation of renal replacement therapy versus a wait and see approach could be used in patients without an urgent or emergent indication for renal replacement therapy, and which of those strategies might be better. This study showed overall no difference in outcome between the initiate now versus wait and see approach. However, it is important to recognize that in the wait and see approach, only about 50% of the patients ever received renal replacement therapy, and those patients who did receive delayed therapy had a worse outcome than patients who received either the early strategy or patients who never received renal replacement therapy, who had the best outcome of all. Another study which focused on a different population that didn't wait for patients to declare themselves as to whether they could continue to wait because of lack of urgent indications, but instead randomized patients relatively early in their course, and also looked predominantly at cardiac surgical patients. And this study was also different in that it really randomized patients not to a early versus wait and see approach, but instead randomized patients to either getting renal replacement therapy at stage 2 or waiting and on average another 24 hours until they reached stage 3. This study showed a clear benefit to initiation at stage 2 versus waiting until stage 3. Importantly, the vast majority of these patients received renal replacement therapy in the delayed arm, which is quite different from the patient population in the prior study. There have been subsequent studies. This one was stopped early. This had a different study design looking at delay of renal replacement therapy in patients with septic sepsis and septic shock, and showed no difference. Again, it was stopped early because of no evidence of benefit. Importantly, a large number of patients in the delayed strategy either went on to die between the early and delayed initiation or required emergent renal replacement therapy, and those findings give us some pause. One concept for decision-making around renal replacement therapy is to really divorce the time concept from more patient-centered questions about a demand capacity balance and imbalance. What this really refers to is the fact that there are different levels of demand that patients have related to their underlying disease burden, their solute load, their volume load, and there are different capacities that patients have, and the sense that patients have a demand and a capacity balance means that they don't need any further augmentation of their renal function. When there is a significant imbalance, one has to judge whether or not patients can tolerate that imbalance and for how long, and that should really guide decisions as to whether one needs to intervene to close the gap between the demand and the capacity. An example might be a patient with only modestly decreased renal function, but who has very severe volume overload, critical cardiac right heart failure, for example, after cardiac surgery, and might even have a high solute load because of hypercatabolic state. That patient's demand is excessive, and even a only modestly decreased renal function might require extracorporeal therapy to manage that patient. Another area is follow-up after acute kidney injury and acute kidney disease. We thought we were being relatively bold by suggesting that patients should be followed at 3 months after acute kidney injury to assess for the development of chronic kidney disease. I would argue now that this is probably far too late and that patients should be monitored much closer to their acute kidney injury event, because I think that 3-month window between AKI and CKD is a window of opportunity to initiate therapies which might be effective or discontinue nephrotoxic agents or better manage blood pressure and diabetes, etc. So I think this is an area that will be ripe for change in the next guideline. This understanding that, in fact, there is a transition in many patients from acute kidney disease, whether it occurred in the context of acute kidney injury or didn't ever make the criteria for acute kidney injury, but had evidence of acute kidney disease that can progress into chronic kidney disease, and the mechanisms of this are still controversial and under investigation, and the therapies that might be initiated are still being developed, but there's an opportunity here for interdicting patients going from acute to chronic disease. We had a meeting in Rome to address these particular topics, and this conference yielded a manuscript which is being submitted for peer review publication presently, and should be available to the community in the very near future. Thank you very much, and we're happy to entertain questions.
Thank you, John. John, I've gone through the list of questions, and they are very exciting questions. I have a few here at the top, and one really addresses the question, what's the difference between acute kidney injury and acute kidney diseases and disorders?
Do you want me to take that one?
Yeah, perfect. Yeah.
Yeah, so I think the answer to that question is wait and see. I think that the concept of acute kidney disease as a predecessor to chronic kidney disease, using the same criteria for chronic kidney disease, but having that present for less than 90 days, was put forth in the prior KDIGO guideline. And this particular entity defined this way has been looked at in some large epidemiologic studies, not very many yet, but a few, in particular the one that was mentioned from Canada by Marlies. This suggests that there is quite a lot of it out there, and it has a significant effect on outcome. There is also a question as to whether or not acute kidney disease, particularly when it arises in the setting of AKI, should be staged, and we should think differently about it, whether the renal function appears to return to normal, but there might be underlying biomarker detectable injury, or when there is persistent renal dysfunction. And when this occurs, there is a very substantial difference in outcome for these patients over both the near term and the long term. And so I think what the next KDIGO guideline will have to address is exactly how best to define and stage acute kidney disease, whether or not it occurred in a context of acute kidney injury, and then how one should manage that particular problem. So for now, I think we can call acute kidney disease that entity which occurs prior to chronic kidney disease, defined either from acute kidney injury or with the CKD definitions, but prior to 90 days. And that's sort of where we are at the moment.
Thank you. We have a question from Rim Ben Dia, and the question is there a difference in definition when dealing with renal transplant recipients? So I can take that. There is no specific definition or classification of acute kidney injury in renal transplant recipients, but clearly the causes of acute kidney injury or the causes of a creatinine rise in transplant recipients may be very different from those in a patient with sepsis or a patient exposed to drugs. At present, the classification as it stands, as I showed it to you, is a generic classification, and it has to be recognized that it may not be fully applicable to all patients. For instance, pregnant women may have acute kidney injury without a significant rise in creatinine, and that's because certainly in pregnancy creatinine is physiologically falls. So the AKI classification and criteria have to be interpreted and applied to the individual patient population and be interpreted accordingly. But back to the question, in transplant recipients, there's no specific different acute kidney injury classification. John, we have a question here related to contrast. And the question is contrast-induced nephrotoxicity related to the type or amount of contrast used?
Yeah, I think that's a very good question, and I think the preponderance of evidence suggests that the amount of contrast does have a role. Larger volumes of contrast, repeated contrast administration increases the risk. There is also evidence that intra-arterial injection of contrast is at higher risk than giving it IV, intravenous. There is also some evidence, although it remains to be, I think, definitively established, that certain preparations of contrast are higher or lower risk of acute kidney injury. Again, there is some evidence that isoosmotic contrast agents, for example, have a lower risk of acute kidney injury than some of the other agents. I think the only thing we can say definitively is that the very old hypertonic solutions that we were using 20 years ago are at are greater risk than the more modern ones. Whether there are differences between the individual preparations in the more modern era, I think is still a little bit controversial, although, as I say, there is some evidence that isoosmotic contrast may be have a lower risk.
Thank you. There's a question here which I could have posed, and it relates to the management of fluids. And the attendee is asking, what is the best parameter to know the adequacy of fluid management? Is it urine output, lab parameter, or central venous measurement?
I think it depends on the patient, right? So I think on the one hand, in the intensive care unit, we could argue that functional hemodynamic monitoring to predict fluid responsiveness is used in conjunction with the patient's hemodynamic status, meaning that if the patient's in shock and they're fluid responsive, that's an indicator that more fluid may be beneficial. And if they're not fluid responsive, it suggests that we shouldn't continue to use fluids. However, it's important to recognize that not all these patients are in the ICU and getting functional hemodynamic monitoring. And so clinical assessment of fluid adequacy in patients has to be modified on the basis of where the patient is and what tools are available. It is important to recognize that urine output is a very poor indicator of fluid adequacy when the kidney is injured. So a good urine output in a patient without acute kidney injury who's getting fluid management may be a good indicator that that fluid therapy is sufficient. But if the urine output falls, one doesn't know if it's because the fluid management is inadequate or whether or not the kidney is now injured and unable to produce a urine output. So I think it's dangerous to continue to fluid resuscitate patients simply because their urine output falls unless you assess the reason for the oliguria. Central venous pressures really have been shown to not be very predictive of where you are in the Starling curve in terms of whether you'll be fluid responsive, and therefore we don't recommend their use as a guide for fluid management. If you're going to use invasive hemodynamic monitoring or semi-invasive hemodynamic monitoring, the role for functional pressures or functional measures is much greater.
Thank you. There are two questions related to estimated GFR. One is the role of estimated GFR in acute kidney injury, and the other one refers to kinetic GFR. So the first question, is there a role for estimated GFR in AKI? In AKI, there is no role for estimated GFR. Estimated GFR is a fantastic tool in chronic kidney disease and stable patients, but it has no role in the acute setting with dynamic changes in renal function. And the other question was, is there a role for kinetic GFR in drug dosing? Again, kinetic GFR is a calculated conceptual model, and the data on drug dosing using kinetic GFR are very minimal. So at the moment, we cannot recommend kinetic GFR either.
I think just to follow up on that, I think the tension for the use of kinetic GFRs and other ways of estimating renal function spontaneously or at the time when you're having to dose the patient is that as the renal function is improving, creatinine and therefore calculated eGFR will grossly underestimate function, and as the renal function is getting worse, those same parameters will grossly overestimate renal function, and that both of those settings is very high risk of leading to adverse drug events. The kinetic GFR is an attempt to try to improve that prediction, but as Dr. Ostermann points out, we have still limited information as to whether or not that approach can be used to better understand how to dose these drugs. What I think we're really hoping for is the availability of a more continuous GFR monitoring to be available in the near future, which will give us a much better sense of what this patient's GFR at the time is. But of course, it will still be in a non-steady state system, and therefore some judgment, clinical judgment, will be required to best dose drugs which are renally cleared in that setting.
John, I've got two questions for you. One refers to the fact that you said 3 months is too late for follow-up after AKI. So the question is, what's your alternative? What would you suggest? When should follow-up occur? And the second question is, when would you introduce an ACE inhibitor or an ARB after an episode of AKI?
So those are great questions. I might punt the second one back to you, Marlies, but to try to answer the first one, I think it is very important to individualize follow-up. So for a patient who's had an episode of acute kidney injury, let's say related to a nephrotoxic drug which you've taken away, renal function has appeared to get back to normal by hospital discharge, it's not entirely clear to me that that patient needs follow-up right away. I think that could wait for a month or so, whereas the patient who's leaving the hospital with still an unstable renal function, either it's getting better, which would be the normal situation as you're sending someone out, or maybe you're concerned that there's been sort of a fluctuating GFR in a patient and you're concerned that the patient may actually still get worse in terms of their renal function. And particularly as you assess that patient, if they happen to be receiving a variety of drugs which are renally cleared, that will dramatically increase their risk of readmission associated with adverse drug events. So I think for all those reasons, one would say that patient requires very close monitoring, and you would perhaps plan to see that patient back in a week after their discharge to monitor their renal function, or at least get a serum creatinine measurement as an outpatient very quickly. So I think the timing for follow-up of these patients, I think, is affected by their clinical features and has to be individualized. In terms of when to start ACE inhibition back, I think that that also has to be individualized. I think that when there is a high demand for a particular agent, for example, a patient who's with congestive heart failure, who ACE inhibition has been very important for their management, the pressure to get that drug back on is going to be much greater than a patient, for example, who's simply using ACE inhibition for management of hypertension and where alternative therapies may be available. So I think, again, and I'd be interested in your opinion about this, Marlies, I think that the answer probably is that you want to initiate drugs when they're necessary and avoid them when they're not necessary. And sometimes clinical judgment has to be used to figure that out.
Yeah, I agree. In particular with ACE inhibitors and ARBs, the article which you showed has very good recommendations highlighting the fact that the judgment on the decision should be based on the risk profile of the patient. And obviously the more risk factors for cardiovascular disease, the earlier ARBs and ACEs should be considered. Clearly, as soon as they get reinitiated, it's important to monitor renal function again. and to accept a small rise in creatinine, but essentially keep the patient under regular review. And that's, I think, is the message. Monitoring and follow-up are key.
Absolutely, I agree. Well, I see there's a lot of questions remaining, and I'm sorry that we don't have more time to cover all of those, but I thank you all for joining this this webinar, and I invite you to read the publication, which will be available hopefully very soon. And I want to thank my co-presenter and moderator, Dr. Marlies Ostermann from London, who gave a spectacular presentation. And thank you all for listening.
Thank you, John. To you too. And thank you to the ISN for organizing this webinar.